Okay, good evening, dear members. It's good to be back here again and ready to hear from our speaker of the day. It's also good to see so many people joining in. Karibuni sana. I see Dr. Gishangi. I've seen Situma somewhere, Dr. Marco, Prof. Gishuhi. Prof. Gishuhi, happy birthday. And all others who have joined in, Karibuni sana from all over the country and outside. Today we have very exciting presentation from Zahra herself. She's just graduated with a PhD. I hope you tell us more about that. For those who don't know me, I am Dr. Wanjiko Mode, an ophthalmologist at City Eye Hospital with a special interest in glaucoma. Today's moderator is a colleague at City Eye as well, doing great things at City Eye. Hi, Dr. Mashep. Dr. Alexandria Mashep is our moderator of the day. So without further ado, Dr. Mashep, karibu.
Thank you. Thanks, Dr. Wanjiko. We are glad to present to you today's discussion on contact lens management in patients with keratoconus. I'm sure it's not just keratoconus, all ectasias or deformities of the cornea, which Dr. Zahra will talk about. First, Dr. Zahra, congratulations on your PhD and on the study, and I'm sure it has been an ennobling process. We are glad to have, seen you go through this and been challenged and encouraged. So without further ado, I'd like you, maybe you can say a few words about the process, and then you can take us through today's discussion. Welcome.
Thank you, Dr. Mashep, and thank you, Dr. Wanjiko. I hope you can hear me, Dr. Wanjiko.
Yes, loud and clear.
Perfect, great. So thank you all for the opportunity. And yes, it's such an honor and pleasure to be here today. I have City Eye to be grateful for in terms of my PhD and lots of other people that supported me. And I'd be very willing one of these days to sit and share. It was a 4 to 5 year journey. But we're finally here. There's a lot that I've learned and I've really grown in the process. That I will, I'm looking forward to sharing with you as the year goes along, right up to the OSK conference at the end of the day, at the end of the year. So, I'll start with this presentation. This presentation today hasn't got anything to do with the studies. We're still in the process of publishing. We've published 2 out of 5 papers. These are the first papers on keratoconus, most likely in Africa. So it's the pioneering work in keratoconus. I think as Kenya, we should be really proud to be leading in this initiative. Those of you who have been publishing, especially in high impact journals, you know that the process is quite long and tedious. And sometimes I think we were discussing today with my professors in South Africa that when we have papers, when reviewers look at papers from Africa, they somehow give us a harder time. But we are being resilient and we keep going back, and hopefully we'll have the other 3 papers published, including the first prevalence of keratoconus in Africa, in an African country. So we're keeping our fingers crossed and we'll have lots to share with you before the end of the year. But for now, today, our main topic is, and I'm just going to share my screen. We're going to talk about contact lens management of keratoconus. And there, Dr. Wanjiko, everybody can see the screen?
I can, yes.
Perfect. Okay, so if you can just look at the screen on the left-hand side, you can we see really advanced keratoconus in this part of the world. It's something that was very new to me, and for many of you, we somehow see more cases than we've ever seen before, and even younger and younger cases as we've been going along. So something is changing, something is different. We are having either we've become more aware of it, especially now that we have cross-linking and we have other management options, or it's also possible that patients have more access now than they've had before. And on the right-hand side, this is just a scleral lens, which I'll talk more in detail. And I'm really pleased because what we've done now over the years is we've actually built our own database and our own photographs, etc. So we're using less and less of pictures from outside Africa. So the non-surgical management, generally in mild to moderate keratoconus, we can use spectacles. From moderate to advanced keratoconus, we use contact lenses. And I get a lot of referrals from many of the ophthalmologists. And the first thing I do when I'm sitting with the patient, what's going through my mind as we are talking about the different options, we ask in terms of what are the visual needs. We get children even as young as 6 years old with keratoconus. So at that point, I'm asking myself, what is the visual acuity that 6-year-old requires if she or he is in kindergarten or in grade 1? Does that child really need 6/6 vision, or will he manage with 6/12 vision and sit in front of the class? So do I really need to fit a contact lens in the 6-year-old who is in grade 1, and I can maybe get him to 6/12 with glasses and he can sit in front of the class and he can cope? However, if I have a patient who is, say, an IT expert, and he's in his 20s and spends a lot of time on the computer, and he needs better vision, I might offer him contact lenses, right? So you always have to ask yourself, what is the patient's occupation, the age, or the class? So we don't have to get all our patients to 6/6. I know sometimes Dr. Mashep sends me a patient and she says, you only gave the patient glasses, but I sent the patient to you for contact lenses. And then I will explain that actually, as we discussed with the patient, etc., we felt that glasses was the best for now, and we'll fit contact lenses later on. So you go through all these questions, and it's a discussion. It's not, I say to all my patients with keratoconus that it's not one method that fits, or one shoe that fits all. We have to discuss it. All depends on the parents, on the child, on the adult, on the, how advanced the keratoconus is. And so it's I find that every patient is an individual on its own, and that there isn't one solution that fits all. We have to remember that keratoconus is asymmetric, and sometimes that's a blessing, but sometimes it's a curse. And it's one eye with glasses, but he is 660 in the other eye. I don't necessarily have to fit the eye with the 660 a contact lens. He'll do very well in school with the eye with 6/9 vision with glasses. So that way, Casey can be, with it being asymmetric, it's actually a blessing. However, as they get older, of course, their binocular visual needs are important. So then they will start coming and saying, well, actually, I want to use both eyes. I feel like I need better binocular vision when I'm driving. And then you start talking about those options. But when they're younger, you can actually work with one eye and then build on all the other options. The other thing is motivation. How motivated is the patient in front of you? The parents might be very motivated that they should have best vision, 20/20 vision in each eye. But I find a lot of the times the boys are not keen on, they're quite happy seeing with one eye. They were seeing all along, and they don't know why they've been dragged in to have a contact lens fitted in the other eye when they can see very well with one eye. So when you're looking at boys and girls, you really have to assess the motivation. Otherwise, if the child is not, or the patient is not motivated, they're not going to bother putting that contact lens in their eye every day. It can be quite cumbersome. So they're not going to put it in every day and then remove it at night or look after it. And parents will have spent a lot of money. So you've got to make sure that your patient is really motivated, because it's a process. The patient has to come in for about 3 visits. They then have to come in for their follow-ups. There's cleaning, there's teaching. There's a lot that goes into this journey when you start contact lenses. So you have to make sure that your patient is really motivated. And then you have to ask yourself, is there allergic conjunctivitis we're dealing with? Do they have eye drops? They might be on steroid eye drops. How are they going to cope with the eye drops? Maybe it's 3 times a day, etc. And together with the itching and the rubbing, do you want to manage the allergic conjunctivitis first before you're going to start fitting contact lenses? Do they have dry eyes? Dry eyes is really simple, because we've got lots of eye drops now in the market that we can use with contact lenses. So that's not really a deterrent. So why is it difficult to fit contact lenses on keratoconic eyes? And this is quite a famous picture you'll see in lots of books and articles, etc. But if you look at the middle picture, you will see that the lens here at the edge, you get an edge lift. So a normal cornea, which is the first image on the left-hand side, you'll find that the contact lens fits nicely, drapes all around the cornea, right from the top to the bottom, and the same thing from horizontally as well. But if you start to see a keratoconic eye, as soon as the cone starts to bulge, you're going to get this edge lift. And then it gets even worse. If you see here, the third picture, there's a bigger edge lift. So I get a lot of patients who come and say, oh, you know, contact lenses, I had such a bad experience. They were terrible. They were really uncomfortable. And a lot of the times is because whether it's optometrists, etc., they're fitting standardized contact lenses on a cone. So what happens, the patient ultimately has, every time the eyelid goes over the contact lens, they actually feel it. So it's such a horrible experience. And they tell you, please, Zahra, I do not want a contact lens ever again, right? But once you start doing them a good fit and you use contact lenses specific for keratoconus, they actually have a completely different experience. And they say, but why was it different when I went somewhere else? And it's more than likely that they didn't use a contact lens specific for keratoconus, but they used one of the regular contact lenses that are used for high myopes. And for high myopes, they will have the regular cornea and it fits well, but it won't fit well for a keratoconic cornea. So that's why there's a lot of thinking, a lot of science. You have to look at your cone when you're fitting. So you have to really spend a lot of time in making sure that we get it as close as possible to the patient's cornea. So what are our different contact lens options? Whenever a patient comes that, you know, what do I have in my bag? And I've done my front for this month. The first thing that you have the top contact lens and that go up really well. Okay, they're great for comfort. Sorry, guys, I think my
We can't hear you.
hear me now?
Yeah.
Dr.
Better.
Better now? You can hear me?
Oh, yeah.
Sorry, I should have used my phone, I think, rather than my internet here at home. But if you can hear me, I won't shift as yet.
We
Okay,
can
may
hear
I
you.
request that you go back to this slide from the beginning?
Okay,
Kindly. Yeah.
I'll start that, no problem at all. So basically, when we're talking about different types of contact lens options, we're talking about what do I have in my bag? So we first start off with the soft contact lenses, because soft contact lenses is something that most people are familiar with. They are easy to put in and out of the eye. They're more comfortable than hard contact lenses, and we can now get them with cylinders up to -6 cylinders. The only trouble with the soft contact lenses is that the vision is compromised, is because it drapes on the cornea. It doesn't regularize any of the deformities caused by keratoconus on the cone. And you have to remember with keratoconus, it's not just about a cone. There's actually irregularities. It's almost like a corrugated cornea. So you actually need something like a hard lens to try and neutralize those corrugations. So it's not just the cone, but the corrugations. But there are some people who are patients who are quite adamant that they will not have a hard lens. So soft lenses are still an option and still something to try. The cost is definitely there. So soft contact lenses actually are more expensive in the long run than hard contact lenses because you have to replace them every month. Whereas if you look at
Sorry, Zahra, do you think we might switch to the other internet?
hard lenses,
Sorry.
their cornea
Dr. Zahra?
Okay, I've switched off my video as well. Can you hear me there, Dr. Wanjiku?
Yep, now you're audible.
Perfect. Okay, thank you, Dr. Jackaji. I've switched to bundles now. And let's go back up there and full screen. Okay, can you hear me? Can you see the slides?
Can see the slide, could hear you clearly.
Perfect. Okay, so we started off with soft toric and we'll move on to the next option. So the next options are corneal lenses. The corneal lenses are usually around 9 millimeters. And if you look at this bottom picture here on the left, you'll see it's where there is fluorescein just from here. So they're usually about 9.4 millimeters. So they sit inside the limbus. They don't go from, sclera to sclera, and that's the difference. So corneal lenses, you just think of them here around 9 millimeters. These are the traditional lenses, and you can see it here on the right-hand side, just where the finger is there. This is the smaller corneal lens. And that's what majority of the patients get. Most of the clinics will do corneal lenses, and they do really well. You get really good visual outcomes, sometimes so impressive. A patient can be 6/120, can have very, very advanced keratoconus, diopters, Kmax of 70, 80 diopters. You put a corneal lens and the patient is reading 612. So you can get really hard lenses do such a good job of neutralizing the astigmatism and the corrugations on keratoconic eyes. So they're amazing corneal lenses. They're generally, the cheaper ones, if you go to see in terms of cost compared to going down to the sclerals or the hybrids. But again, the issue is because they sit on the cornea, the adaptation is required. And I always tell all my patients, I said, look, I can do the corneal lens for you, but I need you to work with me. Work with me for about 3 weeks. It's like going and buying a new pair of shoes. Whenever you buy a new pair of shoes, they pinch you at the front a little bit. For the ladies, we like our high heels. So we'll put a little bit of elastoplaster, but we'll keep going for those 2-3 weeks until we break into our shoes. And that's how I explain hard lenses to the patients. And I say, look, don't give up in the first week. Let's build your wearing time. Build your wearing time in 3 weeks, and your cornea will adapt. Your cornea will get used to the fact of this lens being on top. The tearing will come down, and you'll be a lot more comfortable. And majority of my patients, I would say about 95% of my patients, once they're fitted well, they'll do very well with a corneal lens. So it's a really good option for keratoconic patients. The next one is piggyback. So sometimes they'll come back to me and they'll say, look, Zahra, I tried this for 3 weeks and I really can't manage, I'm really still uncomfortable. What can you do for me? So then I give them the option of a piggyback. And that's what you'll see here in the bottom again on the left. There's a soft lens right in the periphery. You can see that sitting on the sclera, and the hard lens goes on top. So we tell the patients that, look, okay, I can give you an option. I'll cushion your cornea with a soft lens, and then you put the hard lens on top. Again, works beautifully. The only disadvantage is now you have the cost of a monthly lens, and it's got to be a good, breathable contact lens. So it could be a silicone hydrogel monthly lens, and they're looking at spending about another 800 shillings a month per eye now. So the piggyback starts to increase costs, but it does give them the comfort. The piggyback, when I said 5 years lifespan, I meant that is for the hard lens. But remember, the soft lens has to be changed every month, and they have to remove it again every day, in the evening. So you still remove your soft lens and your hard lens. So of course, then, people innovated, and they said, well, instead of doing a piggyback, can we now, manufacture hybrid lenses? Hybrid lenses is where you get the hard lens in the middle and you get the soft lens on the outside. It's like a skirt, but it comes as one lens. The trouble with the hybrid lenses is the cost. The cost goes up significantly compared to any of these corneal or piggyback, but it's less than scleral. And the other challenge we have with the hybrid lenses is that it's the soft skirt around. Whenever patients come back and you remove, you'll tend to find staining around the sclera. So it does really well in the center, but the sclera, you have to be really careful about the fitting, because if that is not done well, again, patients will complain that it's very tight on the sclera. So that fitting has to be done, and it's actually really difficult, even for optometrists. So with hybrid lenses, you tend to spend a lot of chair time with your patient and trying to get the right fitting, etc. And in addition, that the oxygen permeability on the soft lens part sometimes can be variable depending on which manufacturers you use. But again, centrally, you get very good vision and they can wear it. But again, also usually about a year, because the soft lens tends to tear after some time with wear and tear. It's not as rigid as the next option, which is your scleral lens. So I don't do hybrids. I go straight from, I can do soft corneal piggyback, and then I go straight to the scleral lens. And the beauty about the scleral lens is here on the right-hand side, you'll see that it's an entire, literally from sclera to sclera. This is usually about a 14.6 millimeter diameter lens, and it's a hard lens right from one end to the other. And I'll show you later on in terms of, how we insert it, etc. But those are really the best. I find now with scleral lenses that I'm using scleral lenses a lot more. And you'll see the reasons why. I've also put here that with scleral lenses, you have to use saline to insert it. Compared to any of these other options. So unfortunately, it's a whole new way. You have to sit with your patients. It takes a lot of chair time. You have to explain to them. But once they get the hang of it, it's the best thing ever. I've got a patient who's in his 60s now, who's just recently started wearing sclerals, and he's really, really happy. So sometimes we think that, at what age can we start doing sclerals? We can actually, my youngest patient is 13 years old and my oldest is in his 60s, and they actually cope quite well. So the indications of scleral lenses, and thank you to all the doctors who send me patients, because every time they send me a patient, I get better and better at what I'm doing. And I discover as I go along. So, keratoconus with very thin corneas, now that patients come to us with their tomographies, we're able to actually see how thin their corneas are. And if you put a corneal lens on a cornea that is about 200 micrometers, they're likely to get recurrent erosions. So scleral lenses are the best for thin corneas because they're bathing in fluid, whether it's saline or the lubricant. There is no touch. A scleral lens is a no-touch lens. So every time they put it in, the cornea is nicely bathing in that. And so no risk of corneal erosions. For patients who've tried corneal, who've tried hybrid contact lenses, they then come and say, well, can I try a scleral lens? Keratoglobus, of course. Keratoglobus, as you can see here, this image here, actually on the left-hand side, this is one of my patients with keratoglobus. You can't fit a corneal lens, it won't sit. Even if you try and do a piggyback, etc., the soft lens will not sit on it. So again, scleral is great. Patients with PMD, because you've got the steepness is right in the inferior part as well. So PMD works. Superior corneal ectasias. In our study, we found 10% of our keratoconic patients had superior steepness. So again, that would be great for those kind of corneas. Post-LASIK ectasia, post-grafts are great. I used to do post-graft corneal lenses, but now I'm finding that I've shifted all my patients to scleral lenses because now I feel so confident that the graft is just sitting in fluid and I'm not worried about actually irritating the corneal graft in any way. Stevens-Johnson syndrome, Dr. Kabiru sent me a lady and we've got fantastic results. You should see her corneas after wearing. She's one patient that can sleep. You can actually, if you have Stevens-Johnson's, they can actually sleep with their scleral lenses and we fill it with a lubricant. We can put cysteine minims. We don't even put any saline. So they put about 5 drops of cysteine in it and she's able to, sleep with it. And her corneas have healed really nicely. And the other one that I've done recently is corneal scars. So this patient here, if you can look, looks really, really hazy. And we got a really good outcome as well. And recently I had a patient who was fitted in the US and she just has high astigmatism. And she came in, she said, I've read about scleral lenses. Can you fit them for me? And again, she's extremely happy with scleral lenses. So I'm going to just, give you a few examples of case studies so that you can see what we can do and what kind of steepness we're actually getting in our clinics. So this is a young boy. He's actually one of our patients from the study. We had gone to screen kids in Mathare. That was one of the sub-counties that we were screening for the prevalence of keratoconus. And he was in Form 2, already 18 years old, but in Form 2, but was actually, his vision was holding him back. And he had his left eye was really, right eye was even worse. The left eye was his better eye. And if you look at his K max in the left eye is 103.51. Now, most people would say, you know, really, are you going to be able to fit a contact lens on this eye? And we actually fitted a contact lens on this eye. And you can see that his unaided vision was 6/120. And with the scleral contact lens, we got him to 6/24. He can't afford a corneal transplant at this stage. He's an orphan. He wants to finish his schooling. And so we fitted him, and he now comes every 6 months, and he's so grateful, and he's actually managed to progress in terms of his schooling. And what I really like about the tomographers that we see from the MS39 at City Eye is you can actually see the profile right at the bottom. If you look at the profile, you can see how steep this is here. And we can actually fit that with a scleral lens. So that's sort of some of the beauties that and then look at how thin the cornea is. If we look at the thickness minimum, is 186 micrometers. So if you take 186 micrometers and a K max of 103.51, it just shows you what we can do with scleral lenses. Okay, I don't know why my screen has suddenly frozen. Okay, there we go. Next one. So this is a 14-year-old. And the reason why I put 14-year-old here is just to show you that I'm sure most of you, these kind of patients, we are really seeing very advanced keratoconus at very young ages. I'm sure, you know, these would be studies or cases that we can highlight in conferences, etc. Because really we are seeing keratoconus very early and very advanced. So this is a 14-year-old. And if you again look at the profile, it's actually like a mountain, almost like this nipple right at the top. And you can see again how red this cone is here, how wide it is, because if you try to put a regular RGP, a corneal RGP on that, it wouldn't sit because the cone is really wide. And again, this one, the Kmax less than the other patient, under 80 diopters, thickness again 200, but with a scleral contact lens, we managed to get 618 part. Okay, next patient. Again, look at this cornea, quite flat at the top there. And then coming down again, definitely a corneal lens will not sit on that, but a scleral, we got a really good outcome. This is a 32-year-old, already done cross-linking, had got scars in both eyes, but we got a really good outcome. We got 6.9 in each eye. His Kmax was not, you know, too high because obviously we've got this flattening there. Again, very thin corneas there. This is my star case, Dr. Mashep. Thank you for sending this patient over. And you can see this. I've got valleys and hills, and you can see that's her. She's got a little bit. It looks like that, you know, when you just look at it. But the corneal tomography there, and her right eye unaided was 6/240, but with a scleral contact lens we got 624. And she's a unilateral. She's a case of unilateral keratoconus. So of course we have to watch this left eye very carefully, and she's going to come in regular for monitoring. But at least we were able to give her good vision in the right eye. This was a patient post-graft. And sorry, I'm just moving things. Okay, 50-year-old female patient, had already done PKP. If you look at 2016, I think, look at the left eye, the right eye stays pretty stable. But in 2016, the left eye, the SIL was -9. By the time she came back in 2021, her cylinder was -16. She was being followed by her ophthalmologist, but by this stage, then the ophthalmologist sent the patient to me and said, Zahra, can you fit a scleral lens on her left eye? And actually, you know, a lot of patients I find when they come for one eye, then they say, well, can you fit the other eye? So we ended up fitting both eyes. And again, with scleral contact lenses, got really good outcomes. So you can see SILs of even up to -16. We can get really, really good outcomes with scleral lenses. I'm sorry, guys, something isn't quite working here on my. There we go, sorry. Okay, so 14 years old again, and we're finding that we're getting a lot of patients with keratoconus with exotropia, especially because obviously they're not using one eye, the asymmetry, etc. And there we go again with the scleral lens, we get 615 in each eye, and you can see again, this is quite a steep cornea, Kmax of 100, and the left eye 93, quite thin, reasonably. I mean, the right eye is 250 and left eye is 300. And this is again a 14-year-old. Sorry, I think we've gone. Let's go. I'm sorry, it's taken me back. I'll just quickly go through the slides, make sure. Okay. This is a 60-year-old patient I was talking about. He's already lost one eye. The right graft had failed. So the ophthalmologist had sent the patient and said, Zahra, what can you do for his left eye? And with the scleral lens, again, we got 618. And you can see how steep that is. Right there, this is just an image of his of the topography there. But you know, they can be really steep, and in such patients, you know, when they're uniocular, they're not able to see with the other eye. The contact lens can give them a really good option. That one we've done. This was, yeah, again, this was a patient with a scar. Again, look at how steep her corneas are. It's in the range of about 90 there, yeah, 90.86. And again, we were able to fit her eye with a scleral contact lens with a good outcome as well. So even with scars is really, I think for this one, what I wanted to make a point was actually it's about corneal scars. Sorry, guys, I don't know why I'm gonna have to use, yeah, there we go. And the next thing is that children can do it too. It's not just for adults, but this is just to demonstrate to you the process of insertion. So if you look at on the left, they have to fill, there's a plunger. You can use your fingers and make it a tripod, but most of the patients find that difficult. So there's a blue, you can see the blue plunger there. We fill it with saline, and then the patient has to bend down and insert the lens. So that, you know, they usually have to be on a tabletop. It's not like your corneal lenses that you can just whip them in and out. And then that's one of my adult patients who's just demonstrating how to remove it. So there's a separate plunger, which is a smaller plunger that you use to remove the lens. So contact lenses in keratoconus is a good non-surgical option for patients who would prefer that. It improves the quality of vision for sure. It can delay or even avoid the need for a transplant. If costs are an issue and they can't afford a keratoplasty, then, you know, this can give them an option. It's great for children. Like I said, my youngest patient with a corneal lens is 8 years old. And with a scleral lens, my youngest is 13 years old. And in fact, that's the boy here on the bottom there. He lost his left eye after a transplant. It was not successful. And the ophthalmologist was not keen to go back in there and said, look, Zahra, what can you do with the other eye? He wasn't keen on transplanting the other eye. So we fitted him a scleral. Initially, I did him corneal lenses for a very long time. From the time I think he was around 8. And then when he was 13, I thought, okay, let me try and be brave enough and put him in a scleral. And he came back and he said that, you know what, Zahra, I can play football now. You know, and he said, why did you take so long to fit a scleral contact lens in my eye? But of course, I was nervous fitting sclerals in children. So he's my youngest patient, and he gave me the confidence. And I can now, you know, we're being a little bit more brave every time a patient walks in. It's great for monocular patients with corneal ectasias. And really, you know, every time the ophthalmologists send me patients, sometimes I tell them, you know, really, I can't, you know, I don't think I can fit this. And then every time I try, they surprise me. So, and it can be so rewarding when you put the lens in the patient's eyes and they smile like this, and you think, wow, you've really made a difference. So thank you for your time today. And for more interesting cases, what I've done now is I'm trying to get onto the social media bandwagon, and I'm trying to put some of my interesting case studies on Instagram. So if you want to follow me and learn about some of those interesting cases, then, you know, I'm quite happy to share. Thank you. Dr. Wanjiku, I'm going to stop sharing now.
Thank you so much for that very informative talk. I think I'll hand over to the moderator for the Q&A session.
Thanks, Dr. Zahra. That has been most insightful and also very encouraging. There are many, many, many patients we've seen, and you've almost wanted to give up, and then there we are with such good outcomes. So it's been very encouraging. When the floor is open, if you have questions, you can kindly post them, and we will, Dr. Zahra will tackle them. All right, we have a few questions. The first, I think, was from Dr. Walia. Could the cost of scleral lenses be an inhibiting factor for a lot of patients?
Absolutely. Scleral, so let's start with corneal lenses. Corneal lenses, you can get them in like Optica or Kikuyu for around 6,000 shillings a lens. But if you go for the more expensive brands, which are now keratoconus, specific for keratoconus, most of the other optometrists who import from the UK, etc., would be around 13,000. So we're starting with 6,000 for the basic lens, and they can go to 13,000, but that is corneal lenses. And then it's a really big jump. For scleral contact lenses goes up to 55,000 shillings. So scleral lenses generally start at 55,000. But when we explain to patients in terms of the, it's a good investment for 5 years at least. If you look after your lens, and very rarely they will break or crack. It's 55,000. People spend, 55,000 sometimes on glasses as well, right? So when you explain to them and how it's going to change their vision, and once they do a trial, they actually go and find the money and they come back. But I completely agree, Dr. Walia, that it is actually cost can be an inhibiting factor. And there's a reason for it. And there's a lot of, one is the lenses are not manufactured in Kenya or even sub-Saharan Africa. We either have to go to South Africa or Egypt or the UK or India. And with importation, etc., already on the other side, the lenses become expensive. There was a period of time our exchange rate was not favorable. So everything we were bringing in was quite expensive. And now there's a lot of duties and taxes as well that people have to accommodate for the optometrists, plus a lot of chair time. Every patient, your first fitting with a patient can take 40 minutes to an hour, depending on your experience. Your patient then comes back for a collection, will probably spend 1 hour with your staff for a teach, and then he or she will come back again for a aftercare. So that will also take, and what normally happens is it doesn't work with one lens. You may end up modifying that lens 2 to 3 times. It's like going to the tailor. When I'm explaining to my patients, I said, when you go to a tailor and you stitch a dress, you might come back to the tailor and say, well, can you make it a bit shorter? Can you tighten it here? Can you, so it's actually, you're actually tailor making that scleral contact lens for the patient. So it can be 5 or 6 visits before you get the final fit for your scleral contact lens patient. So partly the cost is because of having to import things, but also partly the cost is how much time it takes to get that final fit.
All right, I think second to that was, are there any solutions for making them more affordable?
Not at the moment, something that's, so we're working with a company in South Africa to now that, as part of my PhD project, this was one of the barriers that was highlighted. And so we're working with University of KwaZulu-Natal to see whether, is it really feasible to have our own manufacturing? Why is it that if South Africa can manufacture, but we can't manufacture in Kenya? Can we bring it closer to home? What is required? What kind of investment is required? So that's definitely something that we're going to be working on in the next couple of years.
Okay. On the same, I've seen a few patients come with these contact lenses from India, and they're reportedly far cheaper. Do you have any experience with this, and would you recommend that as one place patients can get these contact lenses?
They can definitely go and get the contact lenses. I've had patients come back with the sclerals, but the problem is the aftercare. If they have to be able to, like I said, it can take up to 3 months to get the right fitting. So if they are willing to stay in India for 3 months, because the lens has to go back and forth to the company, the company will have to then manufacture a new lens, because you'll tell them. So for example, if I'm fitting, I'll even look at the edge on the sclera. So what might happen is at 3 o'clock, I have to tighten. At 9 o'clock, I might have to loosen it. And that only happens as the patient is wearing the contact lens and coming in for the visits. So they have to be willing to stay in India or whichever part of the world they go to for at least 3 months to get their final fit. Once they've got their final fit, they can go to Dubai. There's more fields in Dubai as well. So if wherever they choose to go, they just need to know that they need to be there for at least 2 to 3 months to get their final fitting.
Thank you. There is a comment here from Dr. Nguyo. From your experience, any criteria for telling which corneal scars will benefit from scleral contact lenses?
You know, they surprise me every time. I started with small scars, but the more, challenging cases I get, every time I'm surprised. So I always, there was a patient who was already listed for a PKP. And one of the doctors said, oh, Zahra, just check for me that, and I looked at it and I said, really? There's nothing I'm going to be able to do. I put it on. It was a really huge scar and we got an amazing result. So I picked up and called the doctor and said, well, actually, the patient's got, reasonable vision, functional vision, and they don't want the graft anymore. So they can surprise you and you won't know until you put the lens on.
Thank you, Cindy. Dr. Cindy says you're doing amazing work and we don't want to cause you burnout. So who else can we send such patients to?
So I believe Lions is doing scleral contact lenses. So definitely look at Lions. Eye Care Consultants is doing hybrid lenses because hybrid is very similar to scleral. Again, it's a no-touch lens in the middle. It's just that it's got the disadvantages of the soft skirt. So I would say there's Lions, there's Eye Care. There is another lady, Dimple, who used to be at Lions, and I think she's teaching at KMTC as well. So definitely you've got, Kikuyu doesn't do sclerals, but they do the regular hard contact lenses as well. So they do have a few options that they can go to for now. We are looking again, the challenge is I'm getting a lot of requests from different hospitals to say, come and teach our optometrists how to fit these lenses. We need to sort out the supply chain part first. I think if we sort out the supply chain, then it'll be very easy to roll out training. But there's no point in training optometrists, but then they don't have access to get the lenses because these lenses come with fitting sets. You have to purchase the fitting sets from the companies, etc. So there's a lot to it than just meets the eye. It has to be, we have to come up with an end-to-end solution. But the first thing I think is if we can sort out the supply chain, then we can get all the other pieces to come together. And then there'll be more access for sure.
All right, Dr. Inoti, I believe you've been answered. At least you have a rough idea what the prices are. Dr. Jaffaji asks, what is the end point of a scleral lens? Is there a point that you feel this patient will do better with a graft?
Absolutely. And what we normally do first is I look at the fitting, right? If my last set on my fitting, my steepest lens on my fitting set, I've still got touch, then that's my first indication. I say, look, you know what? My steepest lens doesn't fit on your cornea. So I'm sending you back to your ophthalmologist. You should get a graft done for sure. So that's one indication. The second indication is based on the vision the patient requires. If a patient is happy with 624 vision with the scleral contact lens, then I leave them. I say, look, this is your choice. Decide this is what you can see with the contact lens. If you go for a graft, you might see better after. You may still need a scleral lens, but we might get a better visual outcome after the graft. So you decide and weigh the options. So some patients will say, okay, you know what, Zahra, I'm going to try the transplant. Others are afraid and they say they will not. Definitely less than 624, I tell them, please go back, and look at getting a transplant. So 624 is usually my cutoff. For most of the patients, but it will also depend on the other eye. So if the other eye is really good, they might say, well, you know what, I'm seeing really well with one eye. This eye, yes, is about 624. I'm coping, I don't need it. So again, I look at both eyes and I look at the patient's visual functionality and I give them options and then let them go back and discuss with their ophthalmologist.
Thank you. Dr. Munira asks, if you focus on one eye in children, since it gives adequate vision, then focus on binocularity later, doesn't it affect the binocular development of fusion?
So generally, binocular development is usually done by 2 years of age. If at most we want to say we want to stretch it to 8 years of age, that's perfectly fine. But most of our keratoconus patients come in after the age of 8. So by that time, we're not going to really damage binocularity in any way. We'll just have to see. They could be a patient. I had a 12-year-old boy who was going to go and play for Manchester. He was going for these Manchester, Kenyan boy. He was going for these Manchester tryouts, one of these young, they call them the young schools that they go and play football in. And for him, I had to do a scleral for that 12-year-old boy because it was really important for his sport. But for somebody else who's just in regular school and they want to work with one eye and they're happy. And we talk about school performance every time they come in, because we get them to come every school holidays and say, how are they coping? What is their reading speed like? Are they struggling with their reading? Are there any challenges that the child is having in school? And based on that, then we work on different solutions for them.
Okay. Is there an age at which you feel you now want to start focusing on both eyes?
It's more about what the child's needs are. I don't base it after, because like I said, everybody's after the age of 8. And it all depends on the child's needs. We are seeing some of them with exotropias. So we discuss those options, whether, right at that point, they actually just want to get good vision. They don't even worry about the squint. After a couple of years, they'll come and say, well, can I get a cosmetic result? And even before we want to operate on any strabismus, etc., we want to actually see how both the two eyes work together. So you'll fit both eyes, give them maybe a couple of years, and then do all your measurements, and then send them for strabismus surgery and things like that. But generally, binocularity, I let them come and tell me if it's a specific sport or activity that they need to really use both eyes together.
All right. Thank you. Dr. Wino is asking, at what point does one advise on cross-linking? And is there a role for prophylactic cross-linking on the good eye when only one eye is involved?
So I'm not an expert at cross-linking, and I usually let the ophthalmologists deal with that, because a lot of the patients have already come to me, have had cross-linking. Or are being monitored for progression. Like the case with unilateral, the ophthalmologist said to me, Zahra, I'm monitoring the other eye. I'll see the patient every 6 months. But the affected eye right now, we've already cross-linked that eye. So generally, I don't know, Dr. Mashep, if you want to say anything about your cross-linking protocol.
Well, if it's children, I think we just cross-link them as soon as we diagnose them. We don't give them a chance to see whether they are progressing or not, because many of them, as you've said, by the time they present, they will have already very advanced keratoconus. And if I might add, even the few that we've seen with scars, maybe somebody came with eye drops, it has resolved. Before, when we weren't doing cross-linking on scars, I know scars are a relative contraindication, but we've also found patients progressing even while having a scar. And so if we are getting good outcomes in a patient with a scar, why then don't we cross-link? And they will still at least be assured of not progressing and have good vision with a scleral lens. So for now, we generally are cross-linking, especially children, almost all of them. Yes. Thank you. All right, with the Optometrist Association now in force, any way the authorities can be contacted to get these lenses imported in an easier way. This is a follow-up from Dr. Walia, and he adds that I'm sure some politician has a person known to him or her who has keratoconus.
Absolutely. So unfortunately, right now, even contact lenses, in the US, they call these contact lenses medically necessary contact lenses to differentiate them from the soft cosmetic lenses that people buy from the optical shops. But in Kenya, unfortunately, so even, and the other reason for why scleral, like contact lenses are just hard contact lenses are more expensive, because there's VAT that is attached to that. Now, because we didn't have data on keratoconus, it was very hard for us to lobby Even if I sat with Dr. Gishangi, he would say, okay, give me data. So we finally got data. We have the prevalence, which is unpublished right now. We're looking at the prevalence that we found was 1 in 50 children in high schools in Kenya could have keratoconus. So once we're able to publish this data and we're able to now go to the authorities and say, look, this is what our need is, that's sort of part of this. We've actually got a whole model for the diagnosis, screening, and management that we want to now work on, which will include lobbying for hard contact lenses. We need to start lobbying for things like this. But first, we need the data. So once we've got this data out, we'll be able to do that. So thank you, Dr. Walia. And I'll tell you what I'm doing, Dr. Walia. All my patients that come, I had the marketing manager for Unilever with keratoconus. So I'm actually putting together a list of all these very important people that we will be able to use in the next couple of years to influence things for these children.
Awesome. Eunice asks, you mentioned focusing on one eye for a patient depending on their visual needs. Kindly shed some light on binocularity and amblyopia in relation to this. I think you have tackled it, but you can just touch on it again.
Sure. So amblyopia, we usually worry for children under the age of 8. Majority of our patients that we are seeing are over 8. But I'm not saying we have seen keratoconus in children as young as 5 and 6 years old. So with those ones, obviously, we're a lot more careful. We even do patching, etc., up to the age of 8. But it's the ones that I said I might focus uniocular are those over 8 and who have a lot of asymmetry. Is where you might work on one eye rather than 2 eyes. So usually over 8, I don't worry about amblyopia so much, and I will focus on binocularity based on the child's needs. Like I said, if they're an avid footballer or a golf player, if they have specific needs that they are doing, that they require both their eyes. And it's a discussion with the family and the child as well, based on their needs. And if they really need good binocularity, we'll work with both eyes together.
Thanks. Dr. Jaffaji says, great talk, Zahra. Thank you for educating us on contact lens as a whole and especially on scleral contact lenses. Felix Otwani says, very insightful from Dr. Zahra. Thank you. Dr. Matende says, wonderful presentation, Dr. Zahra. Your great work is appreciated. I think that is all the questions. I had 1 or 2 to ask. As we wait to see if there's any other person who will ask. My one big concern with the contact lens wearers is they tend to depend on it so much and wear it for longer than is recommended. If I have, say, a student in high school.
Sorry, Dr. Mashep, I lost you there a little bit. If you can just
backtrack. Yes. I wanted to ask about patients who are very dependent on their lens. Let me give a typical example. You have a student in high school. They have to wake up for prep maybe at 4:30 or 5. They stay until evening prep around 10. Probably they want to do discussion until 11. So at the end of each day, they've ended up wearing their lens for 15 hours or so. Now, how can we help such patients?
So we do a number of things. One is they need to keep their eyes lubricated, whether they are in a corneal lens, whether they're in a piggyback, or whether they are in a scleral lens. There are lots of eye drops in the market, like Optiv, Optiv Fusion, Refresh, Hylocommode. These are all Sustain. These are all contact lenses that are eye drops that are compatible with contact lenses. So all my patients, especially those who are in schools, we make sure they go with a bottle of a lubricant that they can use. And some of these they can use some of the bottles they can use for 3 months, right? Especially the preservative-free eye drops, most of the bottles. So they go with one bottle, it's standard every holidays. They come see me and they go with a bottle, and we educate them that they must make sure that they lubricate their eyes 3 to 4 times a day. For those who need to wear it for longer periods of time, then we make sure we explain to them that, look, if you have a break during lunchtime, take your contact lenses out, go for lunch, and then put your lenses back on before you. A lot of them have PE and sports activities, swimming, so they will take it out for that and then put it back in. So they do know that they've got periods of time during the day when they can take a break. The other thing, other than lubricating drops and taking breaks, is I make sure that my patients all go with a pair of glasses, even if they only get 660 vision. And I say to them, it's like wearing shoes. You cannot wear your shoes. When you get home, you remove your shoes and you're in slippers. You have to allow your feet to breathe. So the same thing applies to contact lenses and your eyes. So when there's a lot of counseling that goes on during the period of time that they keep coming to see us, and we keep reminding them that make sure you remove, whenever you don't need very detailed vision, like you're not in class, you're not studying, take out your contact lenses, put on your glasses. Because if you're just doing chores like sweeping, etc., you can do that with 660 vision. You don't need to have your contact lenses on for 6/9 vision. So the first thing is lubrication. The second is take breaks. And when you're taking your breaks, you can wear your glasses. So I do that routinely. I don't just send them away with contact lenses. We do the best refraction that we can, and we give them glasses even if they only end up with 660 vision. So that would be the third thing. If they are in scleral contact lenses gives you the highest wearing time. You can wear a scleral contact lens for up to 16 hours a day with no real harm to your corneas. And if you feel that that patient is going to, like, I have a lot of VDU users who are using scleral contact lenses, or patients with dry eyes, we actually get them to put Systane inside the scleral lens. So once they've put Systane inside the scleral lens, the cornea is bathing in that lubricant the whole day. And they can actually go, for many, up to 16 hours quite comfortably. And we haven't seen any, detrimental effect to the corneas as well. In fact, the corneas seem quite happy. So it's just about educating and giving them options. But you're right. And also I tell them on the weekends that give your eyes a break on the weekends so you're ready. When they remove the lens, we give them something like a gel. So you give them a Hylogel or Carbomer at night, or Optive gel, that immediately they remove the lens, they put in the gel lubricant, helps the cornea to regenerate overnight, and they are ready for their contact lenses, whichever ones they're using for the rest of the day.
Mm-hmm. Thanks very much. Dr. Gishui says congratulations to you, Dr. Zahra. Thanks very much. Yes, I don't know if you have any final words.
It's been so, like, this journey in the last, I keep saying keratoconus found me. I know Dr. Gishui has always been an inspiration from my days in Kikuyu when I first came back from the UK in 2001. And I didn't do a lot of keratoconus. In fact, I just used to work on patients with low vision and the pediatric patients. And then when I started my practice in Gertrude's, I just started getting more and more children coming in with keratoconus. And that's how I got better and better at it. And then I was fortunate enough to, I did my master's thanks to Dr. Gishangi at Cardiff University, where I got the scholarship. And that was my first paper that I published on keratoconus on the patients that I see in my clinics. And I remember Dr. Gishui trying to encourage all of us to start thinking about research and how important. So my research, my PhD journey started that just by publishing my 200 patients that I see in my clinic. And I'd like to encourage everybody here to say, look, guys, we have so much that we can share, so much that we can put out there to the world and say, look, and the only way we'll do that is by doing our research. And I think the other thing that has helped me in terms of doing my research is that I'm practicing more and more evidence-based medicine, because as I did research, I had to read. I had to continuously read. So that's made me better at what I do. And it's also been great for my patients as well. So I'd really like to encourage everybody here to try and just take that leap, try and do some research, try and do some reading. And I'm quite happy to support everybody or anybody that they want if they reach out in this journey. And we have OSK at the end of this year. And I don't know if Dr. Manyara is on here, but she will join me to request everybody to please send their abstracts. The deadline will be soon approaching. We'll be sharing the details with you. And we're really looking forward to showcase everybody's work at the OSK. And I know Dr. Karimuri is also working on a Kenya Eye Health Journal. And so we're really going to be reaching out to all of you to share with us your research and your work so that we can all learn and grow together.
Thanks very much. There's been a few late comments. One is congratulations from Prof. Karimurio. Then Dr. Masila asks, what is the practicality of lifelong wear of contact lenses? Do you have patients that wear it like for years and years?
Yes, I have an 80-year-old patient with keratoconus right now, and she started, and she tells me her story of when there was VM Browse, and Dr. Joshi used to be in town. So she remembers that story, that she had started her, and she's 80 years old now, and I'm still managed well. She came to me much later, obviously, in the last 10, 15 years. But she's one example that she has been wearing hard contact lenses from 20 years of age, and she's now almost 80 years. So that in itself tells you that actually patients, if fitted well and they wear their lenses, come for their follow-ups, they can actually wear their hard contact lenses for pretty much their lifetime.
Thank you. I think we've gotten to the end. We'll hand over to Dr. Wanjiku. Thank you.
Thank you.
Thank you both for that very, very interesting topic and conversation and discussion. We've all learned so much. Asanteni sana. And also for your willingness to teach anyone who is interested in learning more about keratoconus and contact lenses as well. Dr. Zahra has mentioned about the upcoming OSK. We request for your abstract to be sent in on time. Links will be sent. There's both OSK coming up and the COEXA Congress. So kindly, any interesting case presentations, any presentations and any abstracts, kindly send them in. Thank you very, very much. And Dr. Makanga says that was a great presentation. I agree. So everyone have a good evening. It is exactly 7:30. God bless.